pancreatic cancer and periampullary cancer. Most important relation of pancreas for oncologists is its relation to superior mesenteric vein and superior mesenteric artery. SMV lies to the right of SME. SMV joins splenic vein behind neck of pancreas to form portal vein which ascends toward liver. Uncinate process of pancreas is attached to SMV and SME by fibrous tissue. Area above SMV in portal vein is called neck. Area to right of neck is called head. Area to left of neck is body and then tail. Common hepatic artery runs along superior border of pancreas and divided to form gastroduodenal artery and hepatic artery proper. Tumors arising from area close to these vessels can engulf major vessel early, leading to inoperability. A tumor in periampullary area is usually resectable as it is away from SMV-SME. However, periampullary tumor is close to common bile duct, leading to early jaundice. Or large pancreatic cancer can approach and involve major vessels, first SMV and then SME. Importantly, this involvement of vessels is from the lateral side. There is an avascular area between neck of pancreas and SMV called tunnel of love. This tunnel signifies plane between SMV portal vein and pancreas. Earlier, surgeons used to pass long artery forceps in this tunnel to check resectability. If tunnel cannot be formed, then it means tumor has involved SMV. However, as earlier said, head and uncinate process involves tumor from right side, hence SMV may get involved from right side even when tunnel of love is free. But formation of tunnel is important as it is the line of division of pancreas and pancreato-duodenectomy Whipple's surgery. Pancreas can be transected over this tunnel safely. A large tumor encasing SMV and tumor arising from neck going into SMV can preclude formation of tunnel of love. Periampullary tumors refers to tumor arising in vicinity of ampulla of Vater. Typically a circle with radius 2 cm and ampulla as center is considered as periampullary area. Structures in this circle are part of pancreas, duodenum, distal CBD and ampulla itself. Any tumor arising in periampullary area leads to early compression of CBD and jaundice, due to which they get diagnosed at early stage. Hence better prognosis. Most resectable pancreatic cancer arise in right side, head and uncinate process as jaundice becomes important specific sign. Conversely, tumor of body and tail usually present with non-specific symptoms. Hence they present late, leading to many cases having mets at time of diagnosis. Jaundice is the most common presentation of pancreatic cancer right side. Jaundice is typically painless, progressively increasing type. Periampullary tumor causes early jaundice, but other tumor cause jaundice when they are large in size. Abdominal or back pain may be due to large mass infiltration retroperitoneal nerves, as pancreas is retroperitoneal structure. Pruritus or generalized itching is due to jaundice. Bile salts irritate nerve endings and skin and cause mast cell destabilization. Weight loss is an adverse feature of pancreatic cancer. Vomiting can be due to celiac plexus involvement by tumor or nodes or by duodenal involvement leading to gastric outlet obstruction. Typical pattern of jaundice in periampullary cancer is painless, progressively increasing type. But in some cases, around 10%, there may be intermittent jaundice where there is waxing and waning pattern. These may be due to papillary type cancer with a polypoid mass in CBD, or can be due to shedding of tumor leading to opening of passage of bile like an ampullary tumor. Such shedding can be associated with melanoma. Hence melanoma with intermittent jaundice can be due to ampullary or duodenal variety. Virchow node is left supraclavicular lymph node present at junction of IJV and subclavian. It receives lymph from thoracic duct. Hence malignant cells from testicular, GI malignancies can reach Virchow node through cisterna chyli and thoracic duct. Sister Mary Joseph node. Based on finding by Sister Mary Joseph, where she noticed that those cancer patients who have nodule and umbilicus palpable have very short survival. Cancer cells may travel to periumbilical area through falciform ligament and ligamentum teres. Bloomer shelf is deposit of shed cancer cells in the rectovesical or rectouterine pouch. Since rectum is adhered posteriorly to sacrum, hence there is no pouch posteriorly. So Bloomer shelf is shelf-like projection of tumor growth palpable perectally and anteriorly and laterally. Specific blood tests ordered are complete blood count. There may be low hemoglobin due to wasting. Increased counts may suggest cholangitis. Serum urea and creatinine for renal assessment. Liver function test would typically show raised direct bilirubin with raised alkaline phosphatase. Mild elevation of SGOT, SGPT may occur. INR may be deranged in deep jaundice as liver synthetic function may be affected. CA19-9 is tumor marker for biliopancreatic malignancy. However, it can be falsely raised in any cause of obstructive jaundice, even benign ones. True value of CA19-9 is when jaundice has settled, like after stenting. Various imaging techniques used in pancreatic cancer are Pancreas protocol CT scan, pancreas protocol MRI, endoscopy, endoscopic USG FDG PET scan. Pancreas protocol CT scan has some predefined specifications, hence is different from routine CT. It is a helical scan with very small slice, less than 3 mm, so that small nodes and tumors do not get missed by falling in between slices, hence not visible. Neutral oral contrast means radiolucent oral contrasts like water. Parenchymal phase means arterial phase when dye has reached pancreatic parenchyma by arteries and enhancement occurs. Pancreatic tumor are peculiar in that they are hypodense on arterial phase in contrast to tumors in other organs where tutors enhance due to increased vascularity. Reason is due to dense stroma in pancreatic ca, there is low vascularity. Portal venous phase leads to enhancement of liver. Most liver mets are supplied by hepatic arteries, and so in portal phase when whole liver glows, mets would appear hypodense. Similarly, pancreas protocol MRI has predefined techniques for increased sensitivity. MRI is although less commonly done than CT scan. Similar to CT scan, thin slices are taken. Diffusion-weighted imaging detects movement of water through tissues. Tumor being dense tissue shows more restriction to diffusion of water molecules than benign tissues. MRCP is magnetic resonance cholangiopancreatography. Here bile being liquid itself acts as dye. It is done for biliary anatomy. Endoscopy is indicated in case of duodenal outlet obstruction. A biopsy can be taken. Ampullary and duodenal cancer can be diagnosed as they project in duodenum. Stenting may be done by ERCP, if indicated. Endoscopic ultrasound is indicated in cases where there is suspicion of malignancy in distal portion of CBD periampullary region, but no mass is visible on CT scan. EUS-guided FNAC can be taken when indicated. Main indication of FDG PET scan is to evaluate indeterminate masses in liver which are small enough to preclude biopsy. If CT MRI is highly suggestive of malignancy, then surgeon may directly proceed for surgery. Biopsy is not indicated in such setting as negative biopsy cannot rule out cancer. Reason is that pancreas cancer has desmoplastic stroma that is intense fibrosis with sparse tumor islands. Hence biopsy FNAC may be negative. Purpose of staging is to define resectability of tumor. If no mets are present, then local resectability is assessed by imaging. Main cause of unresectability in cancer pancreas is involvement of vessels. SMV, SMA, common hepatic artery, and IVC in case of head and uncinate process cancer. 3 categories are defined: resectable, borderline resectable and unresectable. Any tumor involvement more than 180 of circumference means that tumor cannot be shaved off from vessel wall. So either vascular resection and reconstruction is done if survival benefit is present in previous studies, or declared unresectable or borderline resectable depending on the degree of vessel wall involvement. Extensive vessel wall involvement is declared unresectable as it is observed that even with neoadjuvant treatment, these cases never become resectable. Resectable pancreatic head and uncinate cancer is no arterial tumor contact, celiac axis, superior mesenteric artery, or common hepatic artery. No tumor contact with the superior mesenteric vein or portal vein or less than 180-degree contact without vein contour irregularity. Less than 180-degree contact means tumor is touching the vessel but can be separated. Locally unresectable tumor is more than 180-degree contact with SMA or CHA. Unreconstructible vein wall involvement. Vein involvement is so extensive that resection and reconstruction is not feasible. Anything else between resectable and unresectable is termed as borderline resectable. Solid tumor contact with the SMA of less than 180 degrees. Solid tumor contact with common hepatic artery without extension to celiac artery or hepatic artery bifurcation allowing for safe and complete resection and reconstruction. If tumor is close to hepatic artery bifurcation or to celiac axis, then it becomes difficult to reconstruct. Solid tumor contact with the SMV or PV of more than 180 degree, contact of less than 180 degree with contour irregularity of the vein or thrombosis of the vein but with suitable vessel proximal and distal to the site of involvement allowing for safe and complete resection and vein reconstruction. Solid tumor contact with the inferior vena cava. Staging laparoscopy is indicated before surgery when chances of METs are high, like when tumor is more than 4 cm as sites is present CA 19-9 more than 1000 unit per ml. There are small suspicious lesions on imaging, too small to biopsy. It avoids unnecessary prolonged anesthesia if METs are present. Case is abandoned if there are METs. However, if patient is having any need for surgical palliation, if it is metastatic, then laparotomy is directly done as surgical procedure to palliate is also needed. Treatment of resectable cancer head and uncinate process pancreas is pancreatoduodenectomy or Whipple's procedure. Distal gastrectomy is done, or in case of pylorus preserving Whipple's line of transection is distal to pylorus. Jejunum is transected 15-20 cm distal to DJ. Bile duct is cut proximal to opening of cystic duct and CBD. Gallbladder is removed as it will be prone to stone formation after gastrectomy plus. Preserving gallbladder means choledochojejunostomy will be done in mid-CBD. Mid-CBD vascularity is not good for anastomosis. Hence GB is removed and anastomosis is done in proximal CBD. Lastly, pancreas is transected at neck. This is the specimen after resection. For reconstruction, the jejunal loop is brought above through window and mesocolon and end is closed. First pancreatojejunostomy is done, then hepaticojejunostomy and lastly gastrojejunostomy. Some surgeons may put a small 3 cm feeding tube and PJ anastomosis, internal stent, or take stent out as external stent. Feeding jejunostomy may be done for early enteral feeding, and if any anastomotic leak occurs then enteral feeding could be continued. Adjuvant treatment purpose is to eradicate residual tumor. Both adjuvant chemotherapy or adjuvant chemoradiation can be given. In cases of borderline resectable cancer pancreas, in order to shrink tumor to make it operable, neoadjuvant chemotherapy or chemoradiation is given. Benefits are: downstaging of tumor. Radiation is more effective in oxygenated tissue. Post-surgery scarring leads to decreased vascularity in tumor bed. Latent mets can appear during treatment, hence fruitless morbid surgery can be avoided. Unresectable or metastatic cancer pancreas is given palliative treatment, which includes palliation of symptoms and palliative chemotherapy to keep check on tumor. Main symptoms to palliate are pain, jaundice and gastric outlet obstruction. Pain palliation is by using incremental dosage of painkillers starting with NSAIDs and then as required switching to low-potency opioids and then to high-potency opioids. This is WHO step-ladder approach. Resistant pain can be also relieved by celiac plexus block. Jaundice palliation is either by ERCP-guided stenting or surgical palliation by cholecystojejuanostomy or hepaticojejuanostomy. Relieving of jaundice is necessary before starting of chemotherapy. A duodenal obstruction is relieved by performing gastrojejuanostomy.